Okay, so welcome everybody. Just a little bit of background. Today we're going to be talking about topics in clinical care. Everybody up here is affiliated with some sort of real-time clinical care practice with long COVID patients or involved in research or developing programs. Just a bit of a kind of a disclaimer at the beginning. We're not going to be talking about specific medical treatments for individual patients. As we learned yesterday, there's a lot of heterogeneity in the symptoms and ways that long COVID shows up in patients. And so today is really more of a general overview of what we are doing now in real time for those of us seeing patients, as well as what we think needs to happen in the future. So I don't have any financial disclosures. A little bit about me. I am a general internist here in Edmonton. Have two different hats. I work inpatient at the Royal Alex Hospital here, as well as in medical education. And I'm also the medical director of Park Integrative Health, which is a multidisciplinary clinic in Sherwood Park, Alberta, which is where I see long COVID patients. We're going to talk about a clinical case. This is a generic case, but one that might give you a little bit of idea of what we're seeing in our patient population. I've been seeing long COVID patients now since January 2022, mostly from Alberta, a few from out of province. And over the last 2 years, as many of us who have seen long COVID patients, we've honed a little bit of kind of what we're seeing, what we're understanding about long COVID symptomatology, what things may work, what things may not work. So we're going to talk about Janet. So Janet is a 43-year-old female who was infected with COVID in December 2020. She was an elementary school teacher prior to this. And prior to having COVID, she was healthy. She had some asthma that was well controlled. She also has 2 young kids, is married, but unfortunately has not been able to return to work since January 2021. So this is a very familiar story that many of you may be living with right now, or as providers are seeing in their practice. Her primary symptoms include fatigue with associated post-exertional malaise, dysautonomia, and for Janet, it's manifesting as GI symptoms, POTS, and some temperature intolerance. She does get some secondary waxing and waning symptoms that occur when she's in a crash or a flare, such as headache, sleep disturbances, and anxiety. So prior to being referred to a long COVID clinic, Janet has seen a lot of different people. She's been referred to cardiology, respirology, rheumatology, neurology, internal medicine. And she has countless investigations, and many of you that are living with long COVID have probably gone through all of these investigations at some point in your journey, from cardiac, pulmonary, blood work, countless imaging, scans, walk tests, things like that. In 2 years, Janet has been given the diagnosis of POTS based on a tilt table test, but all of our other studies have really not provided extra diagnostic information. In these 2 years, she's primarily been housebound, so most of her appointments with physicians are virtual, and she is bedbound when she has a flare or a crash. She's unable to work or complete daily tasks due to both physical and mental fatigue, and she has become socially withdrawn, developed strained relationships both with her family, her children, her friends, and most recently has been felt like she's being tossed around from provider to provider because nobody seems to know how to really help her. She spent hours and hours searching for any form of hope through treatment, research studies, and online communities, and she just wants her life back. And this is a common story that we've heard over and over and over again, and I think very common for those of you that are living with this, and for providers, this is really what we always hear, is that we really just want our life back. We just want to be able to do the things that we were doing before. So I'm going to switch a little bit from Janet to talking a little bit about currently what I do, what a lot of my colleagues who are seeing long COVID patients as physicians are doing. You know, we've heard a lot about how do we manage it pharmacologically, and the truth is right now we don't really have any tools in our toolbox to manage things from a curative perspective or from an underlying pathophys mechanism. Everything that we might be doing is symptom management. So in my clinic, I treat a lot of POTS and dysautonomia. I'm relying on things, and I think we heard this in a talk yesterday, I'm relying on repurposed things that I've used for other conditions that fit or are similar to the symptoms that I'm hearing with my long COVID patients. And we're trialing and erroring to see if this works. A really important piece that I practice in my clinic, and I'm sure many other providers do as well, is we always talk about risk and benefit. of the different treatments that we're going to try. Because we don't have evidence, we don't have guidelines, a lot of the things that we are trialing are really not meant for long COVID yet, as far as we know. And every medication that we have, we know comes with side effects and may potentially make other symptoms worse. So it is a very case by case, understanding what is important for that patient's symptomatology, their quality of life, their function, and addressing if we have anything in our toolbox that we can use. Rehabilitation, so this is incredibly important when we talk about what can we do now. We've heard all weekend, or all these last 2 days, about the research that is ongoing, the funding that is slowly becoming available for treatment protocols. But in the meantime, there are things that we can do. Finding access to physical rehabilitation, occupational therapy, speech and language therapy to help with swallowing dysfunction, speech, cognition, all really, really key centric things for long COVID management. And then chronic illness, so talking about the grief of the life lost, acceptance, although I do like what John had said earlier about dealing with rather than accepting, and finding that peer support. I think one of the strongest things that I've noticed that's come out of long COVID and long COVID journey in the last few years is the peer support, is the ability for patients to connect with one another. Patients are their strongest advocates, and we need as providers to be advocates for them, but patients connecting with one another is a very powerful tool. So who can provide this care? And we just had this excellent talk from Dr. Rao about multidisciplinary care, and that's really the model that we need to be looking at really for any illness, not just long COVID, but in particular long COVID really would benefit from having some sort of central facet that then allows patients to move out from there for what they need. It can be rehab-led with physician interventions as needed. You know, not every patient may need a particular physician intervention at this moment. They may need more rehab. It might be the other way around, depending on where they are in their journey. Primary care health teams, so including family providers as ongoing support. And we've talked again over the last 2 days about the need for engaging our primary care providers and communities to understanding what long COVID is, what are some of the key symptoms that are associated with long COVID, and what are some of the strategies that they can at least suggest to patients. And then community and home supports. This was really important for me to bring up as well, because we've talked a lot about barriers to care. And I'm going to be speaking really more about Alberta, but we can extrapolate Canada from here as well. But we know that there's a growing primary care problem in this country. Many patients don't even have family physicians, let alone, you know, we talk about family physicians who don't maybe understand or accept long COVID, but even having a family physician right now is a privilege in Alberta. There's often not a physician to be able to refer to certain services, to refer to cardiology, to refer to pulmonary, to refer to rehab programs. Expertise. So the complexity of long COVID, as we've seen in the last couple of days, it can be very daunting for providers. You know, medical physicians have a lot to know and to understand. And as the diversity of the symptoms of long COVID come about, it is hard to keep up with that. So it can often be a barrier for care for patients when their physician hasn't maybe kept up or hasn't been able to keep up with the information around long COVID. Time. So time is a big one. If you've seen me as a patient, you know that our first consultation roughly runs from 90 to 120 minutes because we need that time to be able to go over all of the symptoms that you might be having. But our current healthcare model is actually not set up to support physicians to have that time. We run on a model where we need to get through as many patients as possible so that we can see and provide access to care. But we know that long COVID cannot be talked about in 15 minutes. We know that the complexities of your physical symptoms, your emotional symptoms, and mental symptoms cannot be dealt with in a 15-minute appointment. There are high rates of burnout and moral distress in long COVID healthcare providers who try to advocate for their patients. So, you know, in full disclosure, I'm currently on a sabbatical from my long COVID clinic for this exact reason. I really want to promote and advocate for my patients, but disability form after disability form after disability form, where the patient and myself are incredibly frustrated with trying to advocate, becomes very challenging because we see as providers what patients are going through. You know what you're going through. And it becomes really challenging because in Alberta, there's very few of us that are seeing Dr. Lamb. There's a few of us that are seeing long COVID patients, and we want to be there for everybody, but it's very challenging to do so. So what happened to Janet? So Janet is able to access a specialty long COVID care, and so it does get some treatment for her POTS. She gets some treatment for trying to stay awake a bit more in the morning, trying to balance that with not having too many crashes. She's referred to physiotherapy as well as social work to help her with integration into her new life with this chronic illness, how to manage the social stressors that she's dealing with, her work situation, as well as her physical rehab. But her return to work 3 years into this is still up in the air. And with that, I'm going to pass it to Lauren.
I don't think that's sustainable. Okay. Maybe I will. Oh, it's on. Perfect. Okay. Hello, I'm Lauren, and I'm a physical therapist by background, but I was the clinical lead for the long COVID rehabilitation program for South Sector, so everything from Red Deer down to the US border. And again, I'm going to be speaking from a clinical lens of how we are approaching rehabilitation care and the clinical concepts associated with that in long COVID. So, I have a clicker. All right, moving on. I don't have any disclosures. So the outcomes I'm hoping we're just going to get after is who can provide care, what can care look like, and what are some of the challenges and barriers associated with being able to provide rehabilitation care. So I want to just review what rehabilitation is going to look like. Traditionally, we have this international classification of disability and function. This is how we make decisions about, we use it as a framework for what does the intersection of our symptoms look like as it relates to function, and then what are the personal and external factors that contribute to that overall picture of what that health condition will be. So this is traditionally how we would look at it, but it becomes challenging in long COVID for all the reasons that Dr. Bakshi just mentioned, in the sense that there is extensive testing that often comes back within normal limits, despite the fact that patients are not living within normal limits. And so as clinicians, it becomes very difficult to ascertain what are the structures that are contributing to the functional challenges, and therefore what methodology or rehabilitation is going to be indicated or even appropriate. So this becomes even more challenging with the symptom heterogeneity, which we've heard about extensively yesterday and today. There could be 100 to 200 different permutations for what falls under that structure symptom category of that ICF framework. And so while not everybody presents with all of these symptoms, they often do not present with just one. And so it's challenging to qualify what is the defined functional concern or need, and then when is it met, and is what we're doing appropriate or even effective. So to get anywhere, we need to reconceptualize what rehabilitation for long COVID is going to look like. So long COVID is conceptualized as an episodic disability, and it can be one of the hardest types of disability for the broader community and clinicians to understand, to accept, and to be able to treat. Episodic disability is classified as that vacillation between wellness and disability, calm and unrest, and it's not well appreciated and doesn't make a lot of linear sense to general population, because unfortunately we often categorize disability as being permanent, this black and white categorization as able-bodied or non-able-bodied, and it doesn't give space for understanding disability in a more complex or nuanced way. I have to turn the page. Just give me a moment. Okay. So that's one issue in terms of designing rehabilitation for episodic disability, and then for individuals living with it, it's often invisible, and so you have all of those challenges associated of living with an invisible condition. So, in terms of approaching rehabilitation, in general, there are two different rehabilitation approaches we would take all the time. There is restorative, in that you will return to baseline or maybe exceed it and things will resolve, or there's compensatory. Something has happened, we need to work with what we have, and we don't know what baseline will look like in the future. Right now, in 2024, with long COVID, rehabilitation is compensatory in nature. So the focus of rehabilitation is predominantly going to be about symptom stabilization. We are going to take those waxing and waning symptoms that Dr. Bakshi described with Janet and try and reduce the intensity, severity, and frequency of them via compensatory strategies. And there can be a lot of different strategies that are implemented that are going to be targeted at different symptom presentations, but at the end of the day, they are compensatory in nature. But what rehabilitation is not right now is curative. And that can be a very tough pill to swallow for both patients and providers. And longitudinally, we don't know what will happen. Maybe it will become curative, but right now we don't know. And so while compensatory rehabilitation is not curative, it is incredibly important, and it is currently the cornerstone for management in long COVID. But in order to effectively implement compensatory rehab, there is a considerable amount of illness adjustment that needs to occur. And this is often the first step in making any kind of meaningful gains. And a question as rehab providers we have to ask ourselves is, do we have the right supports in place in rehab settings to be able to facilitate this in tandem with us? So back to Janet. Janet is being referred to rehabilitation for post-exertional malaise, a POTS diagnosis, and some challenges with autonomic functioning, and some GI challenges and fatigue. These are the symptoms that she is being referred to. But these are Janet's symptoms. This is not Janet. And so rehabilitation is not a pill, it is not a prescription, it is contingent on a relationship. And so in any relationship, you need to understand who you are getting into a relationship with. So these are Janet's day-to-day realities. Janet has gone from running marathons to being a teacher, being a wife, being a mother, having interests, being an individual, to being bedbound. Imagine that. So it's incredibly important to recognize those environmental and personal factors that contribute to the presentation of Janet and acknowledging the inconceivable loss that she's going through. We're looking at loss of identity, roles, expectations about the future, self-esteem, self-efficacy. Everything she thought has now disappeared. The other component when we're looking at Janet as an individual is understanding she's living in a chronic state of uncertainty. And uncertainty is a dimension of episodic disability. And I'm not going to talk about episodic disability because Kelly O'Brien is here today. But it is important to recognize that uncertainty. And in simplest terms in long COVID, uncertainty is going to be what is recovery, when is recovery, will recovery happen? There's also uncertainty for providers because we don't know. So we want to make sure that we are acknowledging that uncertainty, and it can be challenging for any individual to be undergoing this level of uncertainty at the micro level, but it's even more challenging in long COVID at the meso and macro level when you look at the attitudes towards COVID and long COVID. Because Janet's also living in an environment where her experience is going to be compounded by stigma, polarization, politicization of COVID towards masks, mandates, vaccines, and belief systems. So when we look at rehabilitating individuals living with long COVID, the mental health impacts cannot be underestimated. Anxiety and depression are some of the most common symptoms of long COVID, and they can also be secondary symptoms as adjustment to long COVID can cause stress and psychological difficulties for patients. There is considerable overlap in the symptoms of neurological and psychiatric disorders that commonly manifest in long COVID. And commonly overlapping symptoms could be pain, disordered sleep, fatigue, cognitive difficulties, mood changes, apathy. And those overlap in symptoms may serve to reinforce stigma as healthcare providers may explain away a patient's symptoms as anxiety or depression, especially if they're given a common screening tool like a PHQ-9, which will overestimate depression for long COVID because the tool assesses fatigue and cognitive impairment, which actually might be solely related to long COVID. So recognizing as a clinician the uncertainty that people are living in is a critical component of your relationship building. And step one is to listen and to not do harm and to not underestimate the impact, the emotional impact of living in chronic uncertainty. So these are some traditional approaches for how we would, their treatment techniques for long COVID. And they are all compensatory in nature. And what you'll notice is that a lot of them are centered around energy management. So you've got education around that push-crash cycle and probably pacing in there, preemptive resting, managing sensory input and how it contributes to the waxing and waning of presentations, finding help. And one of the cornerstones of our rehabilitation strategies is pacing. Right? Who here has heard of pacing? That is smaller than I expected, but okay. Yeah, so pacing. pacing is this thing that we talk about. We talk to our patients about pacing. Awesome. It's the most cited intervention and priority for rehab. And it's a simple concept, right? Break things up, do things slowly, find help, choose, prioritize, put it on a different day. And it can seem really simple. Okay, we've reviewed pacing, check. But pacing is not a tick box, and pacing is not a buzzword. Pacing is an extremely complex therapeutic intervention. It requires people to entirely overhaul their lives, to make decisions about what is meaningful to them and how they're going to prioritize it. It requires consistency. And if you have to ask yourself, what am I going to do today that matters? It means you need to be attached to what matters to you most, which means it needs to be rooted in values and goals. And for the patients in the room and patients that were mine, I want to say that we heard you and you said, that's great that pacing is a cornerstone, but pacing is a privilege. The ability to slow down and to break things up is not available to everyone, especially for patients that are living with financial, housing, food, employment, and relationship insecurity. So pacing is a really important concept, but it is not available and needs to be tailored and flexible to the individual that you are working with, because it will not be the same for everybody. So how do you arrive at a place where Janet can apply compensatory rehabilitation strategies to what she's going through? How do you arrive at rehab readiness in the face of a lot of difficulties and challenges? And the first step is maybe recognizing that you can't do it alone. You are going to need a team. And I can't guarantee that your team will be as diverse in specialty or as cute as mine. But you can at least have one more discipline that you can work with in tandem to help support patients. And these are going to be the heavy hitters: PT, OT, social work, speech, and psych. But you can have adjunct support from dietitians and pharmacy, rec therapy as needed. So when we look at Janet, she's referred for these things that could be managed. Yes, PT, OT, dietitian, and pharmacy, we could absolutely tackle POTS for sure. And all these disciplines could manage these symptoms. But what Janet really needs within her rehabilitation relationship is these components as stepping stones and basic concepts of any relationship, so that validation, communication, values and goals, and longitudinal follow-up, and a social support network. And the role of providers is to help break down the stigma, recognize that there is uncertainty, and make sure that everything that you can investigate can be investigated. And so I'm not going to get into this, but doing it as a team is incredibly important, not just because it's effective and it can meet the needs. It's good for patients, but it's good for you too, because this is work worth doing, but it's so difficult to do it alone. And so I'm going to hand it over now, but thank you. Just going to put these here. Do you want this? Do you want?
No,
Okay.
I think I'm tall enough. Just kidding. Thank you. So sorry, I can't talk. So I'm Dr. Vu. I'm the medical director in British Columbia for the Long COVID Network, and I'm going to kind of go way more upstream to discuss how we provide the services in British Columbia. And after 3 years of existence, we were able to then reflect on how we've been providing the service. I have no financial disclosures. Again, I would like to promote the Long COVID Guide. This is a really good starting point to learn about Long COVID. As we talk about navigating the healthcare system, we've seen, even at this conference, that the terminology is challenging. What it's called is different in the media versus the clinic and research, and policymakers. Like, we haven't decided on one terminology, and as frustrating as it is to patients, clinicians, scientists, and everyone, I think we really need to come to this point. And interestingly, just last month, Dr. Rao brought it up, but the National Academies did suggest using the definition of what they coined chronic systemic disease. And I think all the stakeholders need to be open to that, because I think they wanted to keep it broad so that people can get the necessary resources, supports, and services they need. So the other challenges that we've seen is diagnosing long COVID, everyone said that already. The referral process, again, the lack of primary care makes it very challenging because we are a referral service. Medication treatment options, because things have not been approved for long COVID treatment. We are, everything is still considered off-label. And then lastly is the point that I want to really, press upon you, is the collaboration between GPs and the long COVID clinic. So from the challenges, we looked to patient feedback for direction, and a common theme that was brought up was the need for better communication and collaboration between the patients, primary care teams, and the long COVID clinic. So this is our pathway in the long COVID clinic in British Columbia. It's very clean. Your primary care refers you to the clinic. You go through the process of intake. We encourage long COVID education and courses, practicing them, and we also have physicians, PTs, OTs, social work, a dietitian. We're trying to bring on a psychologist, and at the end of this journey within the clinic, we discharge patients back to their primary care doctors or primary care team. It's very clean, but it should really look like this. Because what we were missing with this guy is there isn't the feedback and coordination, collaboration, co-management while people are learning how to do the pacing, how people are learning about their post-exertional malaise or brain fog, or if they're on medications, how to monitor them. Because we have to be realistic. We don't have huge access to physician specialists. We have 3 docs in our clinic and thousands of patients, and the math doesn't work out. So again, the pathway, we're using the learning health system to really evaluate how we can adjust the service based on feedback and the needs of patients. But it's ever evolving is what we have to accept. So again, my guide is awesome, and it is nationally available. It's been in existence now. It's been launched for a year, and people have used it across North America and then even to like the UK and Australia. There's also the CAN-PCC guidelines through McMaster. And then when patients go through our clinic, we have to consciously track what sessions are useful. And then you could see on the right that the top 3 are fatigue, brain fog, and sleep. So this figure shows the response of patients who attended the fatigue sessions. They're separated by first-time attendees versus second or 3 or more time attending these sessions. And in the fatigue session, you can see that the repeat attendees found this session extremely useful. And I said, note that not all classes have this type of feedback. Versus the dysautonomia and POTS, you can see the top graph is for the information session versus the bottom one is for the discussion session. And the first-time attendees found the information session very helpful, whereas if you've already heard it once, it was less helpful. Versus the bottom, even if you've attended the discussion once, it's quite helpful to repeat it twice, 3 times, because now you've been able to identify POTS, you've been able to identify pacing, practicing like your tolerance and uptime. So the feedback that we do get, it helps us to like direct our care and sort of curate what is provided and helpful to patients. And also it helps us to direct the clinical research because it's ongoing, and it really, again, I can't express how important it is to have patient partners, and we are really lucky in British Columbia to have a very robust patient partnership. So This is from the Interior Health research that we are trying to work with to understand how much primary care docs are aware of our service and how we can help them with education and collaboration. And these are some of the summaries that she recommended, or she found and summarized for us, is that, you know, we need a comprehensive supportive care system because there are no diagnostic tools. It is a clinical diagnosis. It has to be multidisciplinary, interdisciplinary. I have not heard transdisciplinary, but we'll take it. Because no one doctor, no one clinician can do this on their own. And I think the health authorities have to understand that and support that. And it's not just clinical care. I think we're really lucky in British Columbia to have a research arm, an evaluations arm, and an education arm. So we're working with Angela for the ECHO program, and you know, we're all doing the same thing. I don't think we need to reinvent the wheel. So this collaboration amongst us and then amongst primary care is hugely important. So again, this is what we need to continue to strive for, is the ongoing education for family docs, families, patients, and the general public. We've heard lots of lived stories of the frustration of feeling gaslit, and it's just really, really hard. And then we've noted that, you know, the peer groups have been really helpful. And we've also taken on a spiritual counselor to help guide these peer counseling groups. And lastly, again, if I can just say, can we please adopt the National Academy's definition of chronic systemic disease and move forward to getting the services and supports necessary. And I think that is it. Thank you.
Good morning, everybody. I'm Dr. Marina Vasilevsky. I'm a scientist at St. John's Rehab Sunnybrook. My training is in rehabilitation sciences, so I likely would not have seen Janet in a clinical setting, but I would have worked hand in hand with her as a patient partner. And in fact, I have been very fortunate to get to do that for the better part of the last 4 years, to work with people with long COVID, to work with their caregivers, as well as health and social care providers across the continuum to understand this chronic, disabling, episodic condition. I kind of didn't prepare much ahead of time to say, because I was very keen to hear from my colleagues. I was keen to hear from other speakers throughout the day. I did know that I was going to introduce you to our resource that we worked with 24 stakeholders to co-design and co-create over the last few years, and I'm incredibly proud, and it's live now at www.livingwithlongcovid.ca. But I think I'm gonna, as I go through the resource, maybe reflect a little bit on what was said by my colleagues and some of the things that I've heard throughout the symposium. I have no disclosures to make, but I will say a huge thank you to CIHR and the Rehab Sciences Research Network for COVID for funding that's supported this project over the last couple of years. Before I go on to my next slide, I will say that we heard a lot about Janet. We heard how important it is for her to receive clinical and medical care to manage the symptoms that she's living with. But I think it's important to remember that that management is happening in the context of a life. Janet is a person, and she has to manage these things every single day. We heard that Janet might be isolated. We heard that she needs validation. We heard that she needs peer support, and we heard that she is struggling with mental health issues. We also know that Janet has been doing this for 3 years. She has been advocating for herself. Her family has likely been advocating for her for the better part of 3 years. That is a daunting task, without even factoring in the fact that it's in a climate where Janet may not be believed. She has to fight for her rights and her care and supports that she needs every step of the way. Janet is not different from so many of the people with long COVID that we worked with over the last few years, who shared with us their journeys, their needs, and their struggles. Throughout our co-design sessions that we held, it took us 4 months to do 8 sessions. They were so incredibly meaningful and fruitful. We heard that people wanted supports that were public-facing. We knew that people wanted to raise awareness about long COVID amongst the general public because advocating had become very tiring. It's difficult to go to a doctor for care and have to spend the first hour of an appointment explaining what long COVID is or why it's real or why they should believe you. So we endeavored to create a resource with people with long COVID caregivers and providers that was by them and for them, and that's how the Long COVID Education and Awareness Hub came to be. Oh, I did have a slide about motivation. That was the motivation. We heard from people that they weren't getting the supports they needed from healthcare. They were being gaslit. They were being told that things were in their head, and I think these are themes that we've heard very prominently throughout the symposium. And again, the lack of public awareness has been staggering. People are really struggling to get the word out there. And I agree with Lorraine when she said that I think the media is the way forward. We need to bring this to the forefront. We need to put, a face and a name and a story to what people are experiencing and get eyes on it and make sure people are aware. So ultimately, through our co-design activities and our priority setting activities, our group landed on 4 key priority areas that were the foundation for the pillars of the hub. The first was education, the second was advocacy and public health messaging, the third was health and social care reform as well as care integration, and finally, peer support. On the education side of things, our goal was to provide knowledge and resources that were very accessible, easily digestible, and shareable by people with long COVID, their caregivers, health and social care providers. We created several pamphlets that people could print. They're Sunnybrook branded because we heard that that was important for the credibility of these resources. These are things people can use to share with their friends, their family, their colleagues, their employees to help them better understand long COVID. We have infographics and info pages, again, that are short, digestible, and easily shareable. I personally feel very strongly about our advocacy and public health messaging pillar because that really came across as being something that was sorely needed across the country. People need awareness about the impacts of long COVID on daily life, and they need that awareness so that we are combating false information, misinformation that people are still holding on to, including the fact that things like COVID is not real or long COVID is not real. One of the outputs that I am absolutely so proud of from this work is our 5-part docuseries that you can see features our superstar patient partner, Susie Golding, and many other of the people with long COVID that participate in our work, as well as caregivers and health and social care providers that talk about the physical and mental impacts of long COVID, what it's like to manage symptoms on a day-to-day basis, what it's been like for them to try to return to work, and ending with an episode that was somewhat contentious, but about hope and what the future might look like. Our third pillar was focused on health and social care reform and care integration. Here the goal was really, we didn't want to reinvent the wheel, and I think that's a theme we're hearing a lot about. We know Long COVID Web is doing amazing work in terms of trying to unify resources across the country. And so we actually connected with them to get a list of all the long COVID clinics across Canada and integrate them into an interactive digital map that we overlaid peer support groups on as well. One of the projects that we are working on that's coming down the pipeline that's graciously funded by Long COVID Web is to develop a national patient navigation model for long COVID, and we hope that that will begin to address some of the concerns and challenges that we've heard over the last day or two about where to go for care, who to go to, what the care pathways are, what the steps are, and what clinical, medical, or social elements of support would factor into that. And finally, peer support. I agree, and I forget which one of my colleagues it was that said that peer support has been one of the sort of silver linings and most important offshoots of the long COVID movement. We again, there wasn't much we could do in addition to the wonderful grassroots peer support work that has already happened amongst the long COVID community. We did hear that they would have, they would like having that information collated in a space, so we put it on the map. We also heard that it would be beneficial to have evidence-backed guidelines on how to conduct safe peer support groups, whether that be safe from an environmentally safe perspective for in-person groups or a socially and psychologically safe perspective for groups in general. So we did develop a set of guidelines or a how-to guide for how to run peer support groups, and again, have the peer support groups across Canada that are province-specific as well as national in scope outlined on the map. So I guess what I'd finish by saying is that, again, I may not be able to provide any clinical or medical care to Janet, but I do hope that resources like the Long COVID Education and Awareness Hub are a place that she and her family can go to find the types of medical, clinical, and social supports that she needs. Thank you so much, and I'm more than happy to speak to everybody afterwards. Thank you.
Thanks so much for that and all those wonderful talks from the four panelists today. So I will help moderate the questions portion of this workshop. So those in the room, please feel free to make your way up to the mics to ask the question, or if you would prefer, just raise your hand and we've got somebody who can bring you a mic. So perhaps we'll just get started. I've been monitoring the online chat, so there's looks like quite a bit of questions. So I'll hand over to Susan to get started.
Thank you. I'll bring this mic over afterwards. And I'll just note that there's been a lot of requests for copies of the slides, so if the presenters don't mind just completing the consent form so that we can do that, that would be terrific. So the first question that's here is, there seems to be a lot of discussion about the similarities between long COVID and ME/CFS. Should patients with a diagnosis of long COVID who fit the criteria for ME/CFS be diagnosed with that as well?
Yeah, this is a great question. I think this was posted yesterday, actually. It's a great question, and I think I'll kind of say two-part question. I think if we look at the criteria for ME/CFS, unrefreshing sleep greater than 6 months, post-exertional malaise, having either autonomic dysfunction or cognitive fatigue or brain fog, I think most of us can agree that most people with long COVID, and as we talked about with Dr. Vu said, the chronic nature of this illness, are meeting the criteria for ME/CFS. Another kind of point that I'll also point out that we were talking about yesterday with the disability forms, it's one of the diagnoses that if a patient does meet the criteria, I am putting that as their diagnosis. I'm finding from a CPP perspective, from a disability insurance perspective, ME/CFS seems to be more widely accepted than long COVID. That's not correct. We should be accepting long COVID, but in the meantime, often what I'm indicating is ME/CFS secondary to long COVID, secondary to COVID infection.
Okay, great. I think there was a question in the room there.
Hi, I'm Sarah, and I'm an admin for COVID Long Hauler Support Group Canada, as well as a graduate of the PACER program of U of C. So my question is, any suggestions for what we can do as a community in the context of now Alberta's long COVID clinics have been closed or are being shut down, and the wastewater testing isn't happening anymore. We all know that if you follow Moriarty Labs and all of the brain fog, she puts out what her forecast is. And for those of us who follow it, it's almost always high to severe in every single region. So what's the call to action for the community in that context?
Yeah, I mean, I can speak certainly to Alberta, and I think the Alberta jurisdiction is certainly even more challenging than the rest of the country. as we said yesterday, like we don't want to bring politics into it, but unfortunately that is where we are. I think there's a few things that we can do. I think as medical providers and as long COVID clinicians, I think ongoing support for our primary care teams, our primary care networks on education on what long COVID is, understanding how to recognize it in our communities already. And then I think from the other side, as I think Dr. Vipon had mentioned earlier about prevention and really focusing on our small communities on masking, ventilation, those kinds of things. Ultimately, we live in a very political society, and I think it's really reaching out to our local members of government, talking to them about how much this is affecting as we can get more statistics available and published on the effect of COVID and long COVID in this country. Hopefully that will push the needle. It's unfortunate that we can't listen to the other talk right now going on, but I'm sure the economic impact of long COVID is massive. And we know that that might be something that helps move the needle too, as we talk about the economic and financial impact of what long COVID is doing on the workforce and those kinds of things.
I was just going to add that the patient community is like so outstanding, and I think the ability to pull together and support one another as an aftermath of what's happened in Alberta, I think is a really critical component, because a lot of individuals have the tools and the skills, but the chronicity of it is so hard. And I think the ability to stay supportive of one another and create that safe space when we don't have one here is just really fundamental. So maintaining that peer support. And then earlier today, Dr. Rao, when she was talking about having a primary provider, someone that you have a good relationship with, and I don't think it necessarily even needs to be a physician. I think obviously that's easier when it's someone signing off on your forms and they need that physician support, but rehab is really a cornerstone, and rehab professionals are readily available in the community. And so being able to find someone that can go to bat for you and liaise with your medical providers, I think is a good place to start. Just in the current climate though. It's not ideal, but it's the current climate.
Great, thank you so much. Another question from online.
Thanks. A couple of comments really that are related. One is about getting together with local clinicians or all clinicians who have worked in long COVID clinics to compile approaches that are used to submit to the CAN PCC, which is one suggestion. And then the second is really about creating regional long COVID aware specialists to avoid the harms of gaslighting. And this person says, as a GP, I can also attest that questions about non-specific findings on tests may relate to long COVID are almost universally not addressed. With the closure of long COVID clinics, we need to have reliable referral resources. So I think the ECHO program that's being launched will address some of that, but not all of it, I think.
All right, next question from in the room.
Hi, sorry. I'm a person living with long COVID. I'm also an athletic therapist in Alberta here, and through my journey, I've learned as a therapist and have started treating, I guess, rehabbing, coaching long COVID patients in my clinic. Talking about, I think, Lauren, you were the main one that talked about like the multidisciplinary, and myself, I'm in a rural community. Is there advice or ideas on how to link with other medical professionals that are maybe long COVID aware or long COVID specialists to then help me to have more of that collaborative care for my patients?
Thanks, Rebecca. I think it's really challenging when you're working in rural and you're on your own. I think being able to identify what is in scope and what is pushing the edges of your scope is probably the best place, because it identifies where you might need support. So it might not be somebody that's in place yet, but a recommendation or referral to a certain discipline that someone can go and see, and then being able to link up with that person to make sure that your treatment strategies are in alignment. I think it's not as difficult as it once was to find clinicians that are on board now in rehab. And so I think being able to identify what's in scope, what's out of scope, and make a recommendation to your patient and link up with whoever they end up with might be the easiest approach to get that additional clinical piece that you might not have available within your scope. I don't know. What does anybody else think?
I don't think any one individual need to do this alone. I cannot think or imagine of a way for you to corral clinicians. I don't even know everybody who's practicing long COVID in British Columbia, but we have a full team. And even that team is stressed. People go on medical leave and we don't have coverage. So in all honesty, as the medical director, I would not encourage that because you're setting yourself up for failure. I'm sorry.
What I was gonna say was like, do what you can, like, we practice this even as a team in face of like burnout and sustainability and turnover. We didn't have turnover on our team, but we did that because we debriefed and we were supportive of one another. We worked in a transdisciplinary way where we worked at the top of our scope, but we shared roles. So there was overlap in what we provided. So there was sustainability in what we provided. And I think one of our biggest pieces is leaving what's not ours. And I think you do the best that you can do with what you have. And then you have to let go of what's not yours anymore because you'll never make it otherwise.
Yeah, I know I don't want to do it all. I just want to do what is in my scope. But it's the stuff that's outside that I struggle with. Like, how do I find the right people that are not going to like potentially gaslight those patients?
You do your best.
So I gotta, yeah.
You do your best, and you can't control what other people do. And
I think stay in touch with the national forum too, because there are a lot of interested parties and the long COVID web, stay in touch with the town hall meetings. There's lots of expert talks. The ECHO is coming, be involved in that. And, with these conferences, it's a really good opportunity to network, but again, get support.
All right.
I was just going to add one quick comment to that, is that, and it may be more challenging with rural patients who you are the first person they're seeing, but I actually find talking to my patients about who else they're seeing is a really great way for me to keep a kind of running list of therapists that are in the community, physio, occupational psychologists that are COVID aware, COVID sympathetic, COVID empathetic, and I just keep that running list. So if somebody tells me I'm from this part of the city, oh, well, this patient told me that this was a really great provider, why don't we refer you? I may not be able to fully vouch, but I can tell you that if another patient found value, it might be something worthwhile.
Okay, great, thank you. We'll take another question from online.
Great, thanks. So we know rehabilitation needs to be approached with caution due to PEM and PESC. However, some recent studies also show that PEM was not caused or worsened by exercise. And I invite you to read the reply by Ann Bearer. It's very helpful. However, can you speak to how to promote physical activity in long COVID, since we know inactivity also comes with significant health risks?
Thanks. Yeah, it's tricky. And we saw that yesterday with Tanya Janaudas Ferreira's poster that Jillian selected, is that physical exercise or activity or increases in it, in some patient populations, they don't have PEM. And so I agree, as a physical therapist, you don't want to withhold physical activity when it can be so therapeutic because the body is made to move. And even if you're moving at an underloaded capacity, it has such substantial systemic effects. So clinicians have to be very cautious about that blanket statement of withholding movement or withholding exercise. Now, I haven't read this paper, so I can't speak to like the structure makeup of it and intervention, but I would say that PEM can be worsened by exercise, and we've seen it in real time. I'm sure many people in this room right now that are like, what? And so as a clinician, it's like you do the best you can with the information you have and you assess based on symptomology, because that's all we currently have. And so I think we never rule out exercise if it's going to be appropriate, but it needs to be appropriate and extremely cautiously monitored. So it's not to say it's a zero, it's a something, but you need to monitor it responsibly as a clinician.
And I'll just jump in, even though I'm not on the panel, but as a clinician scientist, I think this question really raises the problem that we have in the community with scientific literacy. And so that's not to say that, oh, you didn't understand what you read, that this was above your head. That's not what we're talking about. It's about assessing the quality of the study and also whether it is applicable to your patient population. So like Lauren, I have not read the study, but this certainly flies in the face of a whole slew of other publications. So my question would be, in hearing this new information, is, well, which population did they try this on? Was it a sub-select long COVID population? Because as we've already identified, there are many different phenotypes. Did they capture those that were hospitalized? What was the age group? What was the sex distribution? What were their comorbidities? How long after an infection did they recruit these patients? i.e., what was the definition that they used for long COVID? So that all is super murky at this point, and it is something that I think as a general consumer of the latest research information, it's so important that all of us are looking at the data and say, hey, what is it telling me? Is it using the right population? And is it the right time frame? Is it really, like, what is the question that is being asked? What is the data addressing? And is this actually applicable to me? And so I think that's something really important in this era where there's so much murkiness, so much confusion with definitions and inclusion and exclusion criteria, that we also have to be guarded against maybe being distracted by red herrings or data that, maybe they're looking at a different population than what I am interested in. So that's just something I think really important to keep in mind as we're wading through all the data. Next question from...
Sorry, can I add something to that?
Oh, for sure, sorry.
As a physiatrist, I think it hugely highlights the importance of having a relationship with your physio to know when you're ready to go back to exercise and activities. That's why my guide does not replace the therapy. And not everybody has PEM, and people are ready to go back to their activities, but how would you know unless you actually spoke to a physio? And in rehab, there's always return to play. You don't go back to your activities 100%. It's gradated and gradual and planned. And if you falter, then you pause and go backwards. So it's very individualized, and we cannot just blanket statement that this one program works for everybody. And that's the importance of having ongoing rehab.
Amazing, thanks for that. I think we have time for one last question in person.
Hi, my name is Dr. Fumi Okanola. I'm a family physician and also a co-creator of LongCOVIDTheAnswers.com. My question really, what I found in my work with long COVID and COVID-19 is really, as the very first speaker this morning has said, we were all traumatized during the pandemic. We lost lots of loved ones, and that really hasn't been acknowledged. As a result, anything with COVID in it, i.e. long COVID, carries a lot of stigma. And whenever I tell people about and colleagues about what I'm doing, the minute I mention COVID, their eyes glaze over. I think we need to change the narrative in some respects, and two things spring to mind. There's lots of renowned organizations here that have spoken eloquently and fantastic speakers at this conference, and I think the organizations need to get together and commandeer some mascots. I know it might sound sort of very populist, but we need famous people who have been suffering from long COVID. We need media influencers to take up the banner of long COVID, to publicize and destigmatize it. A really good example was the recent, all the publicity around GL1 agonists. We've known as physicians for over 10 years that these medications, such as Ozempic, can be efficacious in the treatment of obesity. And we've been poo-pooed as physicians for years and years and years by health authorities when we've applied for funding to try and prescribe these medications to our patients. Overnight, there was a social media influencer and a couple of movie stars that proclaimed massive weight loss on it, and now it's a big thing. Now it's being funded. And long COVID needs a similar emphasis. There's a reason why UNICEF always has a mascot like Angelina Jolie or someone like that. Secondly, also, a lot of the things, there's all this talk about family physicians and how they need to be involved. Unfortunately, I would say 98% of my colleagues, even those suffering from long COVID, their eyes glaze over and they don't want to hear about it. They just want to forget about it and move on. And what I've come to understand is that population is just as traumatized as the non-medical population. They were part and in the pandemic too. So again, we need to make it a people always make things about themselves. In general practice, we need multidisciplinary teams who are dealing with huge amounts of complexity in the community. I would say about 20% of our patients need multidisciplinary teams to manage them, and everything is being dumped on our lap. It's not just money and low resource that's driving doctors out of family practice. It's also, a huge workload that we're incapable of managing. We need nurses, physiotherapists, occupational therapists, counsellors to manage the patient lists that we have now. Long haulers need that too. So if the whole narrative can be about a bit more about, we need help, but so do you. If you provide provision for us and our needs, you are going to benefit. You're not going to have to give up your job to look after your elderly mother who needs a PA and several different specialists. If those services are in the community for us, they're there for you. So I'd like to see a little bit more emphasis around those sorts of things to reduce the stigma of long COVID. And then hopefully the medical faculties will see in their wisdom to include it in their curriculum. I had a conversation about how they're trying to depopulate the curriculum at the moment because there's just so much for medics to learn. Well, this is a major disease. This virus affects every organ system. It should be in your cardiology lectures, your endocrinology lectures, your neurology lectures, not just sidelines to infectious disease. And I think if we get the public on board in the ways that I've described, then we can make those sorts of things happen. But it starts with all these wonderful established bodies getting some kind of movie star or social influencer mascot behind whatever you're doing.
Yes. Who knows any celebrities?
I was going to say, Vieta, wasn't there a Vancouver Canuck hockey player who famously disclosed that he had long COVID and could not get back to playing?
I don't know him. No, I think we need to find like one of those ice bucket challenges for ALS. Yes, PR is hugely important.
That person was Suterman, and I approached him, but didn't get a reply, because you find with movie stars and celebrities, unless you know someone who knows them, because they get so many quacks contacting them, they're not going to be open. So it takes an official organisation, something connected to government, to reach out, an established charity, something like that. And there's several here. You can just Google or go to Wikipedia. There's lists and lists and lists of movie stars and famous people in the public sphere that have had or have long COVID.
Well, thank you so much for that suggestion. And if there are interested parties in the audience here or online that have some connections, that would be wonderful. We would love all the help that we can get to get the message out there. So thanks for that creative out of the box thought. Joe, is it?
Just quickly, I have a list of 86 celebrities and politicians that have self-declared long COVID. So this isn't like imagining like Queen Elizabeth had long COVID. This is real long COVID.
Yes.
So reach out to me.
Amazing. Well, thank you so much. And hopefully, through this conference, we can build and further foster some of these connections. Wonderful. Well, thank you so much. And I invite you all to join me and give a round of applause to our panelists.